All right, let's review some practice questions in regards to cardiovascular content within the pediatric system. With all of our practice question videos, I do ask that you pause the video after we initially review the question and the answer options. That way you can come to the answer independently and then certainly resume the video so that we can review the rationales together. Highlight in text physiological integrity. The nurse is caring for a 3-month-old infant who was brought into the emergency department by his mother with complaints of tachypnea and a bluish discoloration of the skin. The nurse is gathering a history and performing an assessment when she notes the following. The 3-month-old infant does have a past medical history of a congenital heart defect. There is mild cyanosis of the lips. Respiration rate is 65. Heart rate is 172. The chest x-ray results in pulmonary congestion, and then an echo confirms the diagnosis of CHF. There is a new physician order for digoxin, 5 micrograms per kilogram twice a day. Now, nursing notes at 3:30 that afternoon. This all, happened sometime in the morning. There's nursing notes at 3:30 in the afternoon. Now the heart rate has dropped to 87. A potassium is noted to be 3.3. The infant is experiencing poor feedings, had 2 episodes of emesis, and a digoxin level comes back at 2.1. So I want you to highlight the findings that are of immediate concern to you as the nurse right now. All right, so any reports of respiratory distress are concerning. So the tachypnea, the bluish discoloration of the skin, the respiration rate being 65, heart rate being 172. And then also we have the heart rate of 87, K of 3.3, poor feeding, emesis, and the digoxin level of 2.1 after the nurse originally and initially administered the order for digoxin. So you need to know and be able to recognize that a normal digoxin level is 0.8 to 2. So signs of digoxin toxicity include poor feeding and emesis. Also, hypokalemia can potentiate digoxin toxicity. So 3.3, a normal potassium is 3.5 to 5, so 3.3 is low. So the hypokalemia may have potentiated the digoxin toxicity, which is evidenced by the digoxin level of 2.1, the heart rate of 87, the emesis, and the poor feeding. Also, whenever you're administering digoxin, it's very important to always check the apical pulse for 1 full minute prior to giving the medication. And if that pulse is less than 90, you're going to hold that medication. You're not going to give it. Classic multiple choice physiological integrity. The nurse is providing education to the mother of a child newly diagnosed with aortic stenosis. Which of the following classic clinical manifestations of aortic stenosis will the nurse discuss in her teaching? So what do you know about aortic stenosis, and what is a classic clinical finding associated with aortic stenosis? All right, the correct answer is activity intolerance. So aortic stenosis is a narrowing or a stricture of the aortic valve, which causes resistance to blood flow in the left ventricle, which causes decreased cardiac output, left ventricular hypertrophy, pulmonary congestion. So a child with aortic stenosis is going to show signs of activity intolerance. They're going to have chest pain and dizziness when standing for too long. Multiple response, select all that apply, physiological integrity. The nurse is caring for a 4-year-old child who is recently diagnosed with Kawasaki disease. Which clinical manifestations would the nurse expect to note when examining the patient? Select all that apply. So this requires your knowledge of Kawasaki disease, and what assessment findings are you going to see in this disease process? All right, so you're going to see a high fever that lasts for at least 5 days, red eyes without discharge, a strawberry tongue and cracked lips, erythema and edema of the palms and the soles, and then bilateral non-exudative conjunctivitis. So Kawasaki disease is a vasculitis that affects primarily children. The diagnosis is based on the presence of fever for at least 5 days and the presence of at least 4 of the following clinical criteria. So at least 4 of the following. They have to have either bilateral non-exudative conjunctivitis, red eyes without discharge, strawberry tongue and cracked lips, erythema or edema of the palms and soles, or a polymorphous rash. Abdominal pain and diarrhea are also common symptoms. However, they are not diagnostic clinical manifestations. And then hoarseness or voice changes are not associated with Kawasaki disease. A drag and drop physiological integrity. The mother of a 2-month-old newborn brings the infant into the clinic for an outpatient routine follow-up. The mother reports intermittent episodes of the patient's face turning a blue hue, which then self-resolves and goes away in under a minute. The nurse notes a murmur upon cardiac auscultation. So just knowing that, just seeing that small bit of medical record, you determine that the patient is presenting with what, and based on that diagnosis, what do you anticipate? All right, so based upon the mother stating, the face turns blue and then it self-resolves, you're going to know that that patient is presenting with what is known as a TET spell, which you see in the tetralogy of Fallot. Also, in the tetralogy of Fallot, it includes the presence of 4 defects. This includes a ventricular septal defect, pulmonary stenosis, overriding aorta, and right ventricular hypertrophy. Classic multiple choice physiological integrity. A 10-year-old patient presents to the clinic with a fever, joint pain, and a rash. The child does have a history of strep throat. The healthcare provider suspects rheumatic fever. Which of the following tests can confirm the diagnosis of rheumatic fever in this child? So which of the following is diagnostic of rheumatic fever? All right, the correct answer is antitreptolysin O titer. So rheumatic fever is a complication of untreated or inadequately treated strep throat, which is usually caused by group A streptococcus. A diagnosis of rheumatic fever is based on the Jones criteria, which includes the presence of clinical manifestations, including fever, joint pain, rash, and the evidence of the preceding streptococcal infection. An elevated antistreptolysin titer is a laboratory test that can confirm the diagnosis of rheumatic fever. So the titer measures the level of antibodies produced by the immune system in response to strep infection.